He's expert in therapeutic EUS, radiofrequency ablations, and pancreatic oncology. Trained at Columbia University of Chicago. Founded echo endoscopy service in Rome, focusing on EUS-guided drainage and tumor ablations. He has over 220 publications, highlights his research impact on advanced endoscopic therapy. Welcome, Dr. Alberto.
Thanks for the introduction. Thanks for having me here in Riyadh. I have to thank for the talk about US-guided biliary drainage because, as you know, basically I arrived in Rome exactly 20 years ago, where I started the US service and arrived in the temple of ERCP. So when the lamps arrived in 2011, my mind started thinking, and I started thinking that in my idea, EUS would have substitute ERCP at least for malignant disease. And I think this is happening, and this will come very soon with the technologies. So these are the procedures that we can do: choledochoduodenostomy, hepaticogastrostomy, antegrade stenting, and we can also drain the biliary system through the gallbladder. So which route to take? This depends on some variables. One, and this is the most important, which is the site of obstruction, so distal CBD or hilar obstruction. Clearly, in hilar stricture, choledochoduodenostomy has no rule. And then also from the anatomy, so if we are in a patient with a normal anatomy, or is a patient with the surgically altered anatomy other than Roux-en-Y, or, and nowadays we are seeing more and more and more, if there is a duodenal obstruction with concomitant biliary obstruction. So, port of entry, duodenal bulb for CBD and eventually also gallbladder, gastric fundus to the left intrahepatics, while a gastric antrum for the gallbladder. Type of drainage, I will not talk about rendezvous that has been, I think, now used only in benign cases. So usually for malignant disease, the most common approach is transmural stenting with a choledochoduodenostomy between the duodenal bulb and the CBD, hepaticogastrostomy between the gastric fundus and the left intrahepatics. Then we have the antegrade stenting that basically is approach from the gastric fundus into the left intrahepatics with a guide wire push through the papilla. At that point, a stent can be placed through the papilla also. And then we have the gallbladder. So let's start with the ERCP failure. So this is a meta-analysis. There are not many studies comparing EUS and percutaneous drainage, and mostly it's because the interventional radiologists do things in a completely different way. So there are not heterogeneous. So there's very small randomized trial with 15 patients per arm, so with no meanings. So they did a meta-analysis that shows that biliary drainage was associated with better clinical success, with fewer adverse events after the procedure, with lower rate of intervention, and was more cost-effective than the percutaneous route. This is another meta-analysis that shows basically that the acute adverse events and the total adverse events were much lower for biliary drainage, and based on all these results, the European guidelines from the ESG, so the European Society for Gastrointestinal Endoscopy, recommend to perform US drainage when clearly possible instead of the percutaneous route because of the adverse events. Let's talk about distal obstruction again after ERCP. This is a comparison between hepaticogastrostomy and choledochoduodenostomy. technical success, clinical success are the same. Studies comparing the two techniques, also technical success, clinical success, the same. But if you look at meta-analysis, hepatogastrostomy is associated with a higher, significantly higher adverse events rate, and the time to recurrent biliary obstruction was more in hepatogastrostomy. So the SG guidelines concluded that in case of distal biliary obstruction, EUS guided choledochoduodenostomy should be chosen instead of hepatogastrostomy because of the lower rates. Another topic, and this is what I was talking about, Laurent, I'll give you the talk later. He's my friend, very good friend. So ERCP US, these are the first three papers. First two, very small sample size. The first is Korean, the second is American from the Varadara-Yulu group. No difference in any variables. Then there is another Korean studies on 125 patients where actually they used a stent that is a DAO stent that has an introducer and has a 50 millimeter uncovered part that goes into the bile duct and an 85 millimeter covered portion that they use for both choledochoduodenostomy and hepatogastrostomy. So in these cases, they perform equally choledochoduodenostomy and hepatogastrostomy. There were no difference in a technical clinical success rate with the ERCP, but the rate of adverse events was much lower or much higher in patients who underwent ERCP than underwent biliary drainage. There was an editorial because this rate of adverse events were determined by a high rate of acute pancreatitis, so that was not basically the usual rate in high volume centers. So this is kind of debated. But as you can see, this is very important. 6 months stent patency was much significantly longer for biliary drainage, and the need for intervention was still lower for the US group. Now we have two more studies. This is international studies that have been done using lamps, using the Axios stent. And this basically shows that the procedural time was shorter in the US group as compared with the ERCP with the fully covered metal stent. The stent dysfunction was the same, and there were no difference in the technical success, adverse events, surgery, and oncological outcome. Another study with a similar design, 155 patients, found that the group who underwent choledochoduodenostomy had significantly higher success rate and shorter procedural time, but all the other outcomes were not different. And most, in this case, I participated to this study, the patients were really advanced, so they had mostly metastatic disease, so they didn't live long enough to measure the long-term patency of the stent. And for now, the ESG guidelines recommend ERCP as a primary drainage for malignant distal biliary obstruction, but US can be considered instead of ERCP in patients who are inoperable in a high volume center, so in endoscopies who has expertise. So this is nice because the hot Axios now is the one used the most to perform choledochoduodenostomy. Is a collected 123 patients who underwent choledochoduodenostomy, 20 had biliary obstruction that was resolved endoscopically in 80% of the cases, and on univariate and multivariate analysis, presence of a duodenal stent and a bile duct thinner than 15 millimeter were considered risk factors for biliary obstruction during follow-up. And Cheng from Canada, we worked together. He put together the data of the two studies published in gastroenterology, and to evaluate stent misdeployment that occur in 70.2% of the patients, so in 11 patients, and classified the stent misdeployment in type 1, distal flange, type 2, proximal flange, type 3 contralateral bile duct injury, and type 4 double mucosal puncture. In all the cases, the adverse events were mild or moderate in severity. And also in this study, multivariate analysis showed that the bile duct less than 50 millimeter was a predictor of stent misdeployment or technical failure. These are the design of the type of classification. I will show you some example. So this is a patient I had a misplacement of the distal flange. I work in a non-fluoroscopic room, so I saw the hole of the bile duct. I placed a guide wire. Then I had a very good nurse that day, so I tell her, call, run, and get a fully covered 4 centimeter metal stent that was placed with no fluoroscopy in the endoscopy room. And the patient went well. She had some pain, clearly, but then the day after was completely normal. Okay. And this is another case. So this is clearly a bile duct from the duodenal bulb. You penetrate with the axios. Here, the axios is open. Then you try to bring it back and release the proximal flange. But the proximal flange didn't work. So what we did is we administered the broad-spectrum antibiotics. We removed the stent with a second stent already available for a second attempt, and then we did the step-by-step opening of the distal flange of the axios. So now the CBD is much smaller, so it's a little bit more difficult, the procedure. You don't see that much, but I can see a lot. And now the stent open. No, it's too much. Same defect. So this is open and the problem is solved. So antegrade stenting, these are the two studies available. There's a lot of studies from Japan using, but on very, very, very few cases. But what is important is this paper is a propensity score match case control study from Japan. So they selected 81 patients who underwent hepaticogastrostomy and patients who underwent hepaticogastrostomy with antegrade stenting. And this is what they demonstrate, that the time to recurrent biliary obstruction was significantly lower if you used both procedures. So if you did hepaticogastrostomy with the antegrade stenting, the overall survival was the same, and the cumulative incidence of recurrent bile obstruction was significantly better for doing both procedure. ILAR, very difficult situation. This is a large retrospective studies. Also for this type of procedure in Japan, they are developing a lot of accessories that unfortunately they stay in Japan. These studies showed that the endoscopic approach was significantly better than the percutaneous, and it was more safe, and the stent dysfunction was much lower than the percutaneous route. And the ESG suggested that drainage with hepatogastrostomy should be done only for malignant inoperable ileal biliary obstruction with a dilated left hepatic duct. I think this will change with time because now there are treatment of ileal stenosis benign, in which the dilatation is not so big as in malignant disease. So this is another very interesting procedure. So instead of doing hepatogastrostomy alone, you do hepatogastrostomy, then you place a guide wire in the right segment, and then you place two stents, one that goes into the right system and one that the usual stents for hepatogastrostomy. And here they compare hepatogastrostomy versus ERCP with the multiple metastelt placement. The time was a little bit higher for the EUS guided procedure, but I think this is also because of, it needs to be done more and more to become as fast as the ERCP guided. But the stent patency was much better, not much, but it was better in the court that where they do the combined drainage. Altered anatomy. So the distinction is between accessible or inaccessible papilla. Let's look at the inaccessible. Well, when we have Roux-en-Y anatomy, you need to do an edge procedure, so to put the stomach in contact with the other stomach and then perform ERCP. When there is when the papilla is inaccessible and there is a Whipple, a BRO2 or other altered anatomy, you can do EUS antegrade intervention or hepatogastrostomy. Finally, this is very important. Patients who have duodenal obstruction that cause not only GO, but also cause biliary obstruction. If you put a LAMS in the CBD, probably will get occluded by the food that goes there because of gravity. So these are the is a small study, 7 patients against 3, so the procedural time was significantly shorter for choledochoduodenostomy, but we know the rate of adverse events was higher for choledochoduodenostomy with 2 cholangitis and 1 case of cholangitis complicated with septic shock that was fatal. Biliary dysfunction was also much higher in patients who underwent choledochoduodenostomy because the food get stuck there and enter into the stent, as it was the dysfunction-free survival. Gallbladder, this is usually done as a rescue procedure. Most of these studies, apart the one from Mangiavillano, in which I participated, are all studies performed when ERCP or EUS guided biliary drainage fail. So they show that this is a feasible procedure. What is important to me is the number of patients that you will treat. So in this study from America, 4 centers, basically, the 28 patients that were treated represented 70% of the total patients who underwent biliary drainage for malignant biliary obstruction, and they performed after failed ERCP and failed biliary drainage. In all these cases, you need, before performing the drainage of the gallbladder, make sure that the cystic duct is patent, because otherwise it's not worth to try unless you have an infected gallbladder. And we are all invited to EUS Skyline, that is a one-day dedicated to EUS online from Asia to United States on December 5th, is a Friday. Thank you very much.